Good afternoon, everyone. Gedien, can we start? Do we have enough people? Yes, we do. 50 participants.
We can go in. It'll be a good session.
Welcome, everyone. I'm Zainab Mohammed. I'm a clinical and radiation oncologist at Groote Hospital, University of Cape Town. And I'm honored and we are very grateful to Key Oncologic for sponsoring our speaker, Professor Fritz van Reer. And he is really the foremost international expert on Castleman disease, and particularly the idiopathic Castleman disease. So before I introduce our speaker and go into his very extensive background, there are some housekeeping notes where you can find the recordings. If there are any questions, please put it in the chat box. And then there's all the information about the CPD. So I know most of the people on the deep dive are regulars. So I'm sure you have, are you familiar with this information? This is the management team for your information. And today we're going to start with a short case presentation. And then Professor Fritz van Reer will tell us about the diagnosis and treatment of Castleman's disease. So here's a summary. Professor Fritz van Reer is the Professor of Medicine and Clinical Director of the Myeloma Center at the University of Arkansas for Medical Sciences in Little Rock, Arkansas. He attained his medical degree in 1985 in the Netherlands, and from there on went to the UK, where he became a member of the Royal College of Physicians and then the Royal College of Pathologists, and attained his PhD. Professor van Reer is a transplant doctor. He's got an interest in, if you look at his research, he's got very broad interest in hematology fields, but particularly in myeloma and particularly in transplantation. But as I said, he is the foremost international expert on idiopathic Castleman's disease. If you look at all the recommendations, you'll see he's the main author. He's a member of the Castleman's Disease Collaborative Research Network Scientific Advisory Board. He's also a member of the European Hematology Association and the ASCO, just to name a few. And I think the last sentence here will just tell us that we've got something very exciting to look forward to, insights into this enigmatic disease, because Professor van Reer was named the Castleman Disease Warrior Award for the Best Physician of the Year by the Castleman Disease Collaboration Network in 2016. So welcome, Professor van Reer. We're very excited to get some more insights into the management of this very enigmatic disease. Thank you.
Thank you for the kind introduction. It's my great pleasure to present to you about the diagnosis and treatment of Castleman's disease. I'm a myeloma doctor, but at our center.
Mr. van Reer, sorry to interrupt you. Shall we start with a case presentation?
Oh, sorry. Sorry about that. Yeah. Go ahead. Sorry.
But thanks. I won't be long. I promise you I won't be long at all. Okay, just stop sharing.
Yeah. Sorry. I must say.
Great. Thanks. So I was asked to do a South African perspective on multicentric Castleman's disease. And that was very difficult because there is no published data on the incidence of multicentric Castleman's disease in Africa. We have, and I'm sure that the nearly 100 participants on this deep dive will be able to attest. The Castleman disease that we see is HIV-related Castleman disease, because South Africa does have the highest prevalence of HIV in the world. And Kaposi sarcoma is one of the commonest cancers that we see in our HIV positive population. So although there's no actual data on Castleman's disease, the burden of Kaposi sarcoma means that we do see quite a bit of Castleman's disease. And I mean, as you can see, we see lots of Kaposi sarcoma in this country. And it seems that the incidence has come down and has kind of plateaued, but we still see a lot of people that are quite immunosuppressed with Kaposi sarcoma. So in my experience at my hospital, which is one institution in the country, and we don't even have the highest rates of HIV in this country, but we've seen about 79 cases of Castleman's since 2005. And I remember the first time we saw this disease, we had no idea what to do with it. And of that, you asked me to present an HIV negative case. I've only got 4 HIV negative patients in all of these years, 2 with unicentric Castleman's disease and 2 with multicentric Castleman's disease. So I thought, let's just do a quick rundown of those 2, just very basic. So this was, and they presented, interestingly enough, I don't know why things always happen in 2s and 3s, you could probably relate. We saw these 2 cases in December of 2012. The first patient was a 42-year-old man, the second one was a 33-year-old man, and their symptoms were pretty similar. The one was more sick than the other, but they had generalized lymphadenopathy, hepatosplenomegaly B symptoms, and both of them had HHV8-associated multicentric Castleman's disease. The one was plasma cell type, and the other one was mixed highline vascular and plasma cell type. They were both anemic, but the patient who was more ill with a shorter history had a hemoglobin of 3.5 grams percent. They were both hypoalbuminemic, and they had these disorganized bone marrow. The first patient was so sick that we didn't even manage to do a CT scan on him, but clinically had a huge liver and spleen. And we treated them both with etoposide weekly for 4 months. For the first patient, he had a CT scan after about, I think, 2 months. When he had a partial response, we decided to continue. But then in January 2014, he actually progressed, and we gave him CHOP. And yes, I'm sorry, that is pretty much how we treat Castleman's disease here, because we didn't have access in the state sector. We didn't have access to rituximab freely, not even for our lymphoma patients. So we treated him with CHOP, but he progressed in 2015, and then we got special permission to use rituximab for him. He received rituximab and etoposide weekly ×4, followed by 6 months of just weekly etoposide, completed in January 2016. For the second patient, the etoposide initially worked, as it usually does, it worked, but after a while, it stopped working, and he actually developed an acute renal failure due to sepsis, was found to have disease progression. We treated him with CHOP as well, 6 cycles, completed in November 2013. And these patients are both well. I saw both of them this year. The first patient, who was quite unwell initially, had issues of cavitating pneumonia and hepatitis. They thought it was drug-induced, but he also had alcohol. Anyway, he was more complicated, but he's well now. The second patient, who was only treated with etoposide and then CHOP, is still clinically in remission, and in fact, it's 10 years later, so I discharged him on the 17th of February. So that is the sum total of my experience at this center, managing multicentric Castleman's disease in HIV negative patients. So I think maybe part of the problem might be that we are not, they're just not being diagnosed. I think that might be part of the issue here in this country. So I'm hoping that you can give us more insights, because I'm sure our hematologists will be very, very interested to know. And I'm also very excited to hear from the audience once you've completed your talk as to what their experiences are, the hematologists. Thank you very much. Okay. Do you have any comments on that? Professor van Reer?
No, I think these are the typical patients who are quite sick, and some of them fortunately do very well. So,
Yeah.
But it's indeed a rare disease. It's a rare disease for everybody.
Absolutely.
Yeah. And I think diagnosis is difficult and often delayed. And I think I'll mention that later.
Sure. Fantastic.
Would you like me to start or? Yeah.
Yeah.
Yeah, okay. All right. Just bear with me. Thank you all for joining. So I'll be predominantly talking about idiopathic multicentric Castleman's disease. I'm a myeloma doctor by trade, and in the 1990s there was a lot of interest in interleukin-6 in myeloma, and we got a patient with Castleman's disease referred, and at that time the director of our center said, well, I don't know anything about Castleman's disease, but I do know something about interleukin-6. So why don't you send the patient our way? So that's the way our center got involved in Castleman's disease, and I've been seeing Castleman's disease patients since 2001. Now, Castleman's disease was originally described by Dr. Benjamin Castleman, who worked at the time at the Massachusetts General Hospital, and described a patient with a mediastinal mass. And this patient had the typical histopathology of what we now refer to as hyaline vascular variety of Castleman's disease. And at that time, it was recognized that it really was a new disease that was presented. This was followed up by a publication in 1956 with a further 13 patients. And this disease entity, which is the unicentric variant, came to carry his name. Okay, so unicentric disease involves a single region of enlarged lymph nodes. Typically, the patients are fairly asymptomatic, and diagnosis is made because of an incidental X-ray finding, or patients just notice enlarged lymph nodes. Typically, surgical excision is curative, and at present the cause is not known. In terms of multicentric disease, I think most of you are familiar with multicentric Castleman's disease in the setting of HIV infection. It can also, this variant can also occur in patients who are otherwise immunosuppressed, for instance, after organ transplant. And in this HHV8 positive variant, the disease is driven by the HHV8 virus and by viral interleukin-6. The approach to this disease is very different. Rituximab is the mainstay of treatment for HHV8 positive multicentric Castleman's disease, and it eliminates a reservoir of HHV8 infection. Then there is another variant of Castleman's disease, the multicentric variant, associated with POEMS syndrome. So these patients have either POEMS symptoms or a number of features of POEMS syndrome. And in any case, they have a monoclonal plasma cell population, which somehow seems to drive this disease. Most of these patients are treated with autologous stem cell transplants. Then lastly, there's the variant I will be speaking about, which is called idiopathic multicentric Castleman's disease, which obviously means that we don't know the cause. It's a systemic inflammatory disorder. We know that interleukin-6 and other cytokines are important, and treatment targeting interleukin-6 can be quite effective. So this is a pictorial overview of the classification of Castleman's disease. Now, if you ask me what is Castleman's disease, I would say it's an heterogeneous lymph node disorder, or a group of lymph node disorders with shared histopathology. So it's the unicentric, the different variants of the multicentric, and then the idiopathic form we subdivide further into the idiopathic, multicentric Castleman disease of Tafro variety, and a variety which we refer to as not otherwise specified. So how are these two variants of iMCD defined? Tafro is an acronym which stands for thrombocytopenia, anasarca, fever, reticular fibrosis in the marrow, and organomegaly. Now, these patients also can have megakaryocyte hyperplasia. They typically have normal immunoglobulin levels, and they may have an elevated alkaline phosphatase. The other feature of these patients is that they're usually quite sick and much sicker than the patients with the other subtype, which we call not otherwise specified. Proteomics studies have shown that this is actually also a heterogeneous group, and I think that we'll further subclassify this in future. So these not otherwise specified patients are less sick. They usually have more thrombocytosis, reactive plasmacytosis in the bone marrow, elevated immunoglobulin levels, normal megakaryocytes in the bone marrow, normal alkaline phosphatase, and they typically have as pathology more the plasmacytic variant, which I will talk about a bit later. So in terms of epidemiology, I have a little bit more insight since we now have a disease-specific code in the United States. And it is indeed a rare disease. There are only about 1,000 to 1,100 cases diagnosed annually. The median age of diagnosis is 50 years. Both men and women appear to be equally afflicted. And it's also important to realize that it can actually happen in children. And children appear to be quite sick with it often. And we're actually in a process with the Castleman Disease Collaborative Network of describing the pediatric cases of iMCD. Now, iMCD is not a trivial disorder. Historically, a significant number of patients have serious issues with this disease. This is a publication showing a 15-year retrospective study of patients with Castleman disease at a number of centers, both in the US and China, with a follow-up of 41 months. And you can see that the 5-year overall survival of patients with iMCD is in the order of 74%. So a significant number of patients actually can die of their disease. Most of these patients did not receive anti-IL-6 directed therapy. There's another often quoted study in the literature by Dr. Angela Dispingeri of the Mayo Clinic, also looking back for a number of years, and she found a similar overall survival of patients with multicentric Castleman's disease. So there's mortality associated with the disease, but also morbidity. Here we look at our Castleman's disease registry from the Castleman Disease Collaborative Network. And this is a study by Dr. Bustamante from the University of Pennsylvania. And the top bar on the left-hand side showed that the patients diagnosed with iMCD in the first year spent about 34 days in hospital. This is compared to 14 days in patients with unicentric Castleman disease, and 22 days for patients people who were in an age and sex match control population. Also, patients on the right-hand side with iMCD are often significantly sick and requiring interventions, such as dialysis, and percentages are quoted here, and even ventilation. So the main message is iMCD gives rise to significant morbidity and mortality, and it's important to accurately and promptly diagnose it and to treat it appropriately. When we started the Castleman's disease Collaborative Network, we realized that there were no diagnostic criteria for this disease. The Castleman's Disease Collaborative Network is an international collaboration between clinicians and scientists, and we developed guidelines for treating the disease. There is a research effort going on. We've got a patient registry for patients with Castleman's disease, and it also provides information for patients. So it also serves as an advocacy organization. So what we did with this group of physicians and scientists is to assemble data from 244 iMCD patients, and we had a number of meetings trying to find consensus regarding diagnostic criteria. We met at a number of occasions at the American Society of Hematology meeting, and also a meeting at University of Pennsylvania where we looked at lymph node biopsies. Then here is what we came up with in terms of the diagnostic criteria. You require two major criteria. One is that you need to have a lymph node consistent with the histopathological spectrum that one sees in iMCD. And ideally, this is ideally one requires an excisional lymph node biopsy. Usually core biopsies are not good enough to appreciate lymph node architecture, and fine needle aspirates are fairly useless in my opinion. Then it's also important to realize that this is not a purely pathological diagnosis. There are other diseases which I'll mention later which can give rise to similar features. So it's a clinical pathological diagnosis. The second feature that one wants, a major criterion, are enlarged lymph nodes in 2 or more lymph node stations. Then there are a number of minor criteria, and these are either laboratory or clinical. The laboratory criteria point to inflammatory response or organ dysfunction, elevated CRP, sedimentation rate, anemia, abnormal platelets, be it low or high, low albumin, renal dysfunction or proteinuria, and polyclonal hypergammaglobulinemia. In terms of signs and symptoms, there are the constitutional symptoms that one sees: night sweats, fevers, weight loss, fatigue, essentially what occurs in an inflammatory syndrome. Then there's an enlarged liver, spleen, the fluid accumulation. Some of these patients have these eruptive chair-red hemangiomata, and there are 2 features that one only sees in the oriental population. These are skin infiltration with purplish papules, and they're comprised of plasma cells. And there's also this lymphocytic interstitial pneumonia, which only seems to occur in oriental patients. Then there are some exclusion criteria. And again, these inclusion criteria are to rule out patients that can give rise to similar, to rule out diseases that can give rise to similar clinical picture and similar pathological picture. So these are infection-related disorders. And I think I've already mentioned HHV8 associated multicentric Castleman disease. Epstein-Barr virus related infections. Another important one is tuberculosis. And then are the inflammatory diseases. Typically, an important one to rule out is SLE, rheumatoid arthritis, IgG4-related disease. And then there are the lymphomas, particularly Hodgkin's disease and non-Hodgkin's lymphoma. So this is my main point here, that it is a clinical pathological diagnosis, and it requires the pathologist and the physicians and the clinicians to stick their head together and think of Castleman's disease. So patients with Castleman's disease present to a variety of specialties: rheumatology, infectious diseases, hematology, oncology, and also internists. It is very often the pathologist who first mention the diagnosis, and because of its rarity, this is a disease in which the diagnosis is often delayed or sometimes even missed. So the pathology, although not diagnostic of Castleman's disease, is important. And also the pathologist can help to exclude other disorders. So although I am not a pathologist, I will try to say a few things about the histopathological spectrum that one sees in iMCD. There is on one hand the high vascular variety. On the other end of the spectrum, there is the plasmacytic variety, and in between, one can see mixed pathology disease. Some of the features that one looks at are regression of germinal centers, follicular dendritic cell prominence, vascularity, then hyperplastic germinal centers, and plasmacytosis. Some of these features are more prominent in Highland vascular variety disease and others in plasmacytic variant disease. So this is the Highland vascular variant pathology, and one can see here prominent hyalinization. There can be onion skinning with hyalinized vessels. The centers are more atrophic and regressed, and sometimes one can see the twinning of follicles, these follicles very close together. Here's what we call a lollipop that one sees in Highland vascular variety disease. Here are the B lymphocytes, these onion rings of B lymphocytes, and there's a radial penetrating vessel here. And the patients with the Tafro syndrome very often have a very vascular lymph node. And we sometimes use the term hypervascular variety of pathology for this. So when you look at these lymph nodes under the microscope, they're quite striking. They're very vascular and relatively poor in cellularity. And there's lots of proliferation of blood vessels. Then the other opposite of the spectrum is the plasma cell variant. And you can see here hyperplastic centers. Then there are lots of plasma cells in the interfollicular space, relatively preserved lymph node architecture, and normal follicular dendritic cells. I'm going to skip this one. And here you can see again these expanded mantle zones, these big follicles, sheets of plasma cells between the follicles. And when one does immunohistochemistry, obviously the plasma cells will stain for CD138, and there's typically no light chain restriction. So they will stain both for kappa and lambda. Now, how should the ideal diagnostic process work? And often, obviously, this does not happen in real life. One should try to get an excisional lymph node biopsy. If there is a PET scan available, we usually go for the hottest lymph nodes, which is easily accessible. Then hopefully it comes, hopefully one Castleman disease is thought of at this time, then a CT scan or PET scan will be able to differentiate between unicentric disease or multicentric disease. If it's multicentric disease, one wants to exclude all the diseases that I already mentioned. Then one arrives at a diagnosis of multicentric Castleman disease, and one can then further subtype it, exclude HHV8 associated disease by LANA1 staining of the lymph node or by PCR for HHV8 on the peripheral blood. And POMS-associated MCD should be fairly easy to recognize as well. Now, although we don't know the exact cause of iMCD, it is clear that cytokines play an important role. Interleukin-6 causes the liver to excrete increased CRP. It leads to elevated CRP levels. IL-6 is also responsible for the inflammatory syndrome. Also, IL-6 interferes with the hepcidin axis and decreases the use of iron, thereby causing the anemia. IL-6 also reduces the production of albumin by the liver, so there is hypoalbuminemia. That, together with increased vascular and endothelial growth factor, can cause a capillary leak type syndrome with the severe anasarca that one can see, particularly in the Tafro patients. IL-6 also causes your fibrinogen to rise, and that results in increased sedimentation rate. Now, the increase in fibrinogen also promotes the formation of blood clots, and there's an increased risk of DVTs and pulmonary emboli in Castleman's disease. Now that we've established that IL-6 is important, it's obviously important to realize that one can actually target the IL-6 axis. There is tocilizumab, which is an antibody that recognizes the anti-IL-6 receptor and binds to it. And that antibody is approved for the treatment of Castleman's disease in Japan. And then there is siltuximab, which got a very high affinity for IL-6 and directly neutralizes interleukin-6 and interferes with signal transduction and the JAK-STAT pathway. So back in the 1990s, we already treated at our center a patient with anti-interleukin-6 antibody. This was an antibody that came from France and provided by Dr. Weidenes, and that antibody was temporarily effective in a patient with Castleman's disease. However, it had a very short half-life. It was murine, and it was not further developed clinically. However, siltuximab that I show here originates from the Netherlands, and that antibody has now been commercially developed. The purpose of this slide is to show you that it's been extensively studied in a phase 1 dose-finding study, in the only randomized double-blind placebo-controlled clinical trial in iMCD, and it's been studied in a long-term extension study for its safety. And there have also been several other publications on this, on siltuximab, some of them which are mentioned here. So all in all, siltuximab has been very well studied in Castleman's disease. This is an example from the phase 1 study. This is one of my patients, a young man who had a large mediastinal mass and some other lymph nodes. And you can see the PET scan before and after 2.5 years of treatment. The FDG avidity is gone, and also the lymph node mass obviously has disappeared here on the CT images. This picture I got from Dr. Kurtrock from MD Anderson Cancer Center in Houston. And this is a patient with skin lesions, and one can see that skin lesions gradually resolve during therapy. Now, the encouraging results in the phase 1 study led us to explore this antibody in a randomized placebo-controlled trial. This was conducted at 38 centers in 19 countries, including North America, Europe, we had the Far East, Singapore, Taiwan, South Korea, New Zealand. We had countries from South America and Africa, I think Egypt and Brazil took part. Anyway, this was quite a big effort to study this particular drug in a controlled fashion. So there were 79 patients with HIV negative, HHV-8 negative disease randomized in a 2-to-1 fashion, either to receive study drug or placebo, and the placebo arm was allowed to receive 1 milligram per kilogram prednisone or equivalent. These patients were followed for response, both tumor response and clinical response. And more recently, we looked at progression-free survival and overall survival, and also at the time to response and the various components of response. That is a lymph node response, the normalization of abnormal laboratory parameters, and improvements in symptoms. So here one can see on the left the response rate in the placebo and in the siltuximab, and this is the durable tumor and symptom response, which occurred in 34% of patients in the siltuximab arm, and 58% of patients remained on study at primary endpoint analysis. This is the tumor response only visualized on the left by independent review and by the right, on the right by investigator assessment. The purple bar are the siltuximab patients and the greens are the placebo, and one can see here that clearly there's a higher response rate in terms of lymph node reduction in patients treated with siltuximab. Time to treatment failure was also superior in the siltuximab treated patients here in purple. And the time to treatment failure was in fact not reached. And it was only 134 days in patients receiving placebo. And in fact, some of these patients did get prednisone. Then more recently, we analyzed progression-free and overall survival. Now, on the left-hand side, one can see the progression-free survival. The red is the siltuximab arm. The blue is the placebo arm. In the placebo arm, the 2-year progression-free survival is 37 months. And it is in the siltuximab-treated patients, it's 91%. So it's 91% versus 37%. Siltuximab also did better in terms of overall survival, but it was not statistically different. Perhaps because patients who failed placebo were allowed to receive siltuximab off study. Some of the patients in the who were initially on the placebo arm later still received siltuximab. Now, how quickly do patients respond? I think it's important to have a feel for this because the antibody, it's an IgG antibody, it's given every 3 weeks, and it will take some time to reach steady state. So it requires a number of doses to exert its effect. Now, one can see that response in some of the laboratory markers, such as platelet count, CRP, albumin, hemoglobin, occurs fairly quickly. Markers such as fibrinogen and IgG responded later in this study, but they were also measured less frequently. Now, one can see that improvement in symptoms occurred fairly quickly. So if one starts a patient on siltuximab, one can see improvements in laboratory parameters and symptoms fairly quickly. However, the lymph node response lags behind considerably. So it's important to realize that siltuximab merely neutralizes a growth signal for lymph nodes, but it doesn't work like a cytotoxic agent or like rituximab. So it takes time to see a response. Then the changes in laboratory markers are pictorial shown here. On the left-hand side, the improvement in hemoglobin, and here the green dots are the siltuximab, a sharp reduction in CRP, reduction in sedimentation rate, and improvement in albumin at the right lower quadrant. Now, who responds best to siltuximab? And here we compared responders to non-responders. And here you can see patients with a higher fibrinogen, a higher CRP, a lower albumin, lower hemoglobin, and higher IgG levels seem to be responding better. So you have a higher chance of responding if you have laboratory evidence of an inflammatory response. We also looked at this by in terms of clinical parameters such as minor criteria. And here we looked at symptoms, and if you're more symptomatic at more minor criteria, then you're also more likely to respond to siltuximab. Now, siltuximab is given every 3 weeks, and in principle, it's lifelong. So it's important to appreciate how safe this drug is when it's given lifelong. And for that purpose, we conducted a long-term extension study, and 19 patients from the phase 1 study and 41 patients from the phase 2 study were enrolled. And of these 60 patients, 18 discontinued prior to 2-year data cutoff. There were 2 adverse events, 2 had progressive disease, and there were also patients who came off study because they started commercial siltuximab once it was approved by the FDA in the United States. So these patients were in median for 5.5 years on study. They received a median number of doses, which was 86, which was quite high, and all were alive. And the middle showed there were only 2 patients who had disease progression. In terms of patients coming off because of adverse events, there was 1 patient who went on study with abnormal liver function test and had to come off because of increased in liver function abnormalities. And 1 patient came off study because of a severe accident. Even when one considers any patient who came off study for any reason, including the patients who went on to receive commercial siltuximab, then there was still a 70% continued control rate of the disease. Now, what about tolerability? This is a very detailed slide, but let me give you the, I think the main messages. First of all, it's quite well tolerated. The drug is easy to administer. In terms of an administration side effect, you need to think more like a rituximab, so that it's not a big problem to give this drug. We did not see any opportunistic infections. So no viral reactivation, CMV, or other viruses and also no fungal infections. So as a single agent, long-term, there are no unusual opportunistic infections, and it's well tolerated. One can see slight elevations of cholesterol, and some of the patients did get anti-lipid therapy. Then what is not on this slide, but it's personal experience, there are some patients with mild thrombocytopenia, platelet count between 100 and 150,000, because IL-6 is important for thrombopoiesis. And there are some fleeting rashes, which I've not seen, but which have been reported, mostly managed with topical corticosteroids. So overall, this is long-term safe drug. And this is one of my patients who went on it in 2005. At that time, his wife had just died of cancer, and he was told that he only had a few years to live with this disease, and he was very worried about his then young children. And he went on the phase 1 study and now has received more than 300 doses, and fortunately is doing well. And this is my patient on the left here. So where does siltuximab fit in the overall treatment paradigm for iMCD? Again, with the Castleman Disease Collaborative Network, we sort of realized that there was no standard approach for this disease. And when you look at the literature, there are actually no systematic studies except for siltuximab. And one study was tocilizumab in Japan. And people had used a variety of treatments like steroids, chemotherapy, and whole plethora of immunomodulatory agents, and even autologous stem cell transplant. So we tried to make some sense of this, and we developed international consensus treatment guidelines for iMCD. We reviewed the clinical trials, the published literature. We looked at 344 cases that we accumulated, and we recommend treatment based on severity of the disease. Severe iMCD, we defined as follows. You need to have 2 out of 5 of these: poor performance status, significant renal dysfunction, fluid overload, low hemoglobin, or pulmonary involvement. Pulmonary involvement, if untreated, will eventually progress to pulmonary fibrosis. In clinical practice, it's not very difficult to recognize who has severe iMCD, and these are the TAFRO patients, and they usually wind up in intensive care. And on the left-hand side is David Feigenbaum, who was my patient at that time, and with whom I founded the Castleman Disease Collaborative Network. And he described his experience in a book called Chasing My Cure, which is a very entertaining read, I think, and also very illuminating. So this is the paradigm that we came up with. Now, I think that we probably made a mistake by labeling patients as non-severe versus severe. On the right-hand side, when we talk about severe iMCD, we really think about life-threatening disease. On the left-hand side, you can non-severe disease, but these patients are still sick enough to actually be, or some of these can still be found in hospital. And so this is non-severe versus severe. The non-severe patients get us, we recommended treatment with siltuximab if available as first option. And we preferred siltuximab over tocilizumab since it's better studied. Tocilizumab has only been studied in one single-arm Japanese study. If you respond to treatment, you go on essentially indefinitely with siltuximab. If you have an inadequate response, then we recommend using rituximab and steroids In particular, our British colleagues like to add an immunomodulatory agent such as thalidomide. If you have severe disease, you'll usually complement your cetuximab with high-dose steroids. If there's no response, then one can consider giving combination chemotherapy, which is a very difficult decision since these patients are often quite critically ill. They don't have a cancerous disorder, and then one proposes to give actually combination chemotherapy like CHOP or something different that we use for myeloma, like VDT-PACE. Obviously, patients respond. You taper down the steroid dose and continue them essentially lifelong on cetuximab. If you do see somebody with very severe disease, we usually recommend to get in touch with somebody who's seen this before. And on our Castleman Disease Collaborative Network, one can find a list of physicians who's willing to advise. Then the Chinese have published some options when monoclonal antibodies are not available, particularly thalidomide, cyclophosphamide, and prednisone, but also bortezomib and Cytoxan and dexamethasone. So there are other options available if antibodies are not available. Now, these are already a little bit old data, but when we looked at the uptake of cetuximab in the United States, we saw that initially only a small percentage of patients here in green was treated with cetuximab first line. And here one can see patients second line, third line, and fourth line. And Dr. Mukherjee from Cleveland Clinic accumulated this data. So overall, only 8 to 9% of patients received cetuximab therapy. And this is one of the reasons why we've been trying to do educational talks in order to, first of all, improve the awareness of the disorder of Castleman disease per se, the various subtypes, the diagnostic process for iMCD, and also the available therapy, specifically cetuximab. Obviously, and I already alluded to this, if you don't treat promptly, there are significant morbidities and mortalities associated with this disease in terms of organ dysfunction and thrombotic events. And again, there is a mortality associated with this. So overall, I think it's important to consider the diagnosis. The histopathology is not diagnostic. However, often the pathologist is the first person to think of it and to alert the clinician to the possibility. I think the pathologist also plays an important role in trying to exclude some of the other disorders that can give rise to similar histopathology. From the pathologist's perspective, the most important point is to actually think about the disease. The exact histopathological subtype is not that important because it doesn't direct therapy. The therapy is directed by the presence of the inflammatory syndrome and targeting interleukin-6. Now, cetuximab, we feel, is the best study drug. That's why in our guidelines, we gave it category 1 evidence. I try to highlight that I think that the long-term administration as a single drug is safe and effective. No unusual infections, it's well tolerated, and no cumulative toxicity. In terms of responses, your symptomatic, excuse me, your symptomatic and laboratory response occurs quickly. And the lymph node response is much more delayed. Also, don't use IL-6 to measure your response. Cetuximab binds to IL-6, and even one dose of cetuximab will falsely elevate your IL-6 levels. In effect, you measure IL-6 inactivated and complex with siltuximab. Your best marker as a bio readout of disease activity is not IL-6, but the C-reactive protein. And I think I will leave it here for some questions, and I thank you all.
Thank you very much, Professor van Reer. That was very interesting, very enlightening, and I'm sure that there are questions. I don't see any questions in the chat, but there is a comment from one of our hematologists in Bloemfontein, Jacques Malherbe, was saying, you can't remember ever treating any HIV negative Castleman patients. So that is pretty much our problem. The HIV positive and the HHV8, the ones that are HIV negative will have HHV8 multicentric Castleman. So we're not seeing a lot of idiopathic here. So why is it unsafe? I mean, I know there've been no studies or no trials, but why is it considered unsafe in the HIV positive setting?
The siltuximab or the...
Yeah.
Okay, so the main driver of the disease in HHV8 positive disease is viral interleukin-6. And I believe it got only 23% homology with human interleukin-6. So siltuximab does not bind well to viral interleukin-6. And there has been one limited trial of tocilizumab at NIH in HHV8 positive Castleman disease, and also that did not show any activity. So again, in HHV8 positive disease, there's a reservoir of CD20 positive plasmablasts, which harbors the virus, and that needs to be targeted with rituximab, with or without etoposide.
Thank you very much. I know you don't have any access to the chat. I don't know if you can see the comment on the chat from Erica Marie Nell, who thanks you for your insights. And she noted that HHV8 multicentric Castleman's was a separate diagnosis from POEM's multicentric Castleman's on the algorithms, and wanted to know if our HHV8 multicentric Castleman's patients could have POEM syndrome.
So in principle, it would be possible, but you really would have two totally separate disorders, two very rare separate disorders. So typically one does not see POEM syndrome in HHV8 positive multicentric Castleman disease. I've never heard of a patient. And
then Jacques Malherbe from Bloemfontein again comments that it's possible that many patients are actually undiagnosed and may die before diagnosis is made. So I think it's really great that we have this educational session to be more aware of it, so we can give our physicians more advice when dealing with patients that present in this way. I'm also just curious.
Yeah, so if I may comment that, I think that is probably quite feasible that that patients pass away before they diagnosed. I've certainly seen some. A few of my patients have been very, very sick and late diagnosed, and even young people, a young man who had a stroke and bowel resection and all sort of problems. So I think it's very possible that late diagnosis leads to mortality. Yeah.
Okay. Yeah. I was just curious. You showed us some skin lesions in a patient that responded to treatment. What were those skin lesions? Was it POEMs? Obviously not.
No, that's a very interesting phenomenon. So you see these are sheets of plasma cells in the skin.
Yeah.
So they're these purple lesions, and you only see them in patients, Peloponnesian patients, and in Oriental patients, and of Oriental ethnicity. So I have two patients who've never been in the Far East, and they've only been in the States, and they have this. And so it's somehow tied to ethnicity. I've never seen it in an Afro-American or white patient, so that's very, very, very interesting. And we don't know, apart from the issue of race, we don't really quite know how this works.
That's yeah, that is interesting, because if I see lesions like that, I think Kaposi sarcoma. Are there any more questions on the chat? So if anyone wants to pose a question. Does anyone want to comment from the hematologist side on what you actually see in the field, or what you see out there?
I think one of the things that I've sort of learned from doing some of these talks for a number of audience across the world actually, is that the role of the pathologist is very important, because usually it's what the pathologist reports that triggers the diagnosis of Castleman's disease. So the awareness of pathology is very important for this disease, to raise at least the possibility.
Absolutely. And I think in our country, before the HIV epidemic, we didn't know anything about this disease. And it was probably nearly 10 years ago when we first started seeing it in association with Kaposi sarcoma. So I think there is an index of suspicion when people look at lymph nodes. I remember we had a patient referred to us who had typical Castleman's disease on the lymph node, but she also had rheumatoid arthritis. And Estelle Verberg and myself had a very tough time trying to sell her back to the rheumatologist to say, this is your patient, you must treat her. She has rheumatoid arthritis. Unfortunately, there were the diagnostic criteria that we could use to back up what we said. So yeah, thank you for that. So if there are no other questions, I'm just curious about the cost of being on a lifelong cetuximab. That must be quite prohibitive for patients.
Yes, it is expensive. I don't. On the other hand, some of these patients have been very sick, so and the drug works very well and very well tolerated.
Yes.
So a lot of my patients are very unwilling to stop the drug or come off therapy, but it will require some form of insurance coverage for most patients, unfortunately. Yeah.
Yes, because they can be very, very unwell.
Yeah.
I mean, I've just looked at, I just Googled while you were talking about your colleague, David Fajgenbaum.
Yeah.
He nearly died 4 times because of this Castleman's disease, and he had to find a cure. So yeah, thanks for that tip. I think that might be an interesting book to read.
Yeah.
There is a question from Eric Heffer. Is the presence of HHV8 virus a driver of progression, and should it be treated directly?
No, so these are completely separate entities. So HHV8 associated multicentric disease and idiopathic are completely different. So they're not related.
Thank you very much. Any other questions from the audience? Well, there's some thank yous for the talk, and thank you very much for the talk. I can't think, I'm just wondering if anyone in the private sector has ever come across this. So Elizabeth has asked a question that I can actually answer after listening to your talk. Can you use IL-6 as a monitoring tool if you give chemo like R-CHOP?
The answer is yes. However, IL-6 is difficult to measure. Commercial antibodies used in assay vary in their performance. IL-6 also has different splice forms, and sometimes it binds to macromolecules like alpha-2 microglobulin. So even in HHV8 positive Castleman disease, the recommendation would be to use something like CRP, because IL-6 measurement is difficult. For you, those of you who are very interested in this, there's a paper by Kate Sasser, Sasser, I think in the British Journal of Pharmacology in 2015 on different assays. It's a very instructive paper. Anyway, so CRP is the thing to go for rather than repeat IL-6 measurements, whether you use an antibody targeting IL-6 or not.
Can you see the other question? There's comment. There's some data that VALG and cyclovir activity in HHV8 positive MCD. They've used it in relapse patients with success. So yeah, we've seen that. Eric Oxenheimer.
Eric Oxenhandler from Paris is one of the world authorities on HHV8 positive disease, and it has been used. But I think it should be considered a possible additional therapy rather than a replacement of rituximab. Rituximab should be your mainstay.
Yes. And then Garrick Lordlin asks whether there's any crossover or progression of one type of poems to another. For example, an MCD presentation and then a transformation to a more plasma cell type phenotype, and is there a role for myeloma type therapies in MCD like bortezomib or thalidomide, lenalidomide?
So these different forms of multicentric disease are quite distinct, and one does not progress to the other. The other thing is, basically with multicentric, with iMCD, they can present with waxing and waning disease. They can have slowly progressive disease, and they also can have these huge flare-ups, which land them into intensive care. So the patients, you typically stick to their pattern of the disease. So if you have patients with slowly progressive disease, that's what they will do. They won't suddenly get a big flare. Patients who have big flares and then quieten down, they may do this again if you don't have them on effective therapy. Then myeloma therapy. So I do use myeloma therapies sometimes for patients with iMCD who are very severely ill, who have the Taffer syndrome and who are not responding to antibody therapy. And for those of you who know myeloma, there is combination chemotherapy used, VD-PACE, and we use that without the cisplatin component, but that's something that we do at our center. Other people sometimes use CHOP-based or add CHOP with etoposide.
The last comment is just to thank you again and saying that there are very few of these patients, just generally, even in the HIV setting.
Yeah.
But the one thing to know is that if it does happen and it's really terrible, you do need to know how to manage patients like this.
Yeah.
I always, when these patients were referred in the beginning, we didn't know anything about managing them. But now, whenever they come, I see people getting blood transfusion upon blood transfusion, and I tell them it's like pouring the blood down a drain. You're not going to do anything unless you switch off those cytokines. So we stop aside to switch off the cytokines. Great. Any other comments from anyone?
Just from my side, Zainab, I thought it was a really great session, and you are our Castleman expert, and I do think, as you said, you should know these patients. Otherwise, you have no clue how to put all these symptoms and the whole picture together. But they do reasonably well, often.
If you get them over that initial phase, right, Professor Van Reer?
Yeah, I agree with that. I think the initial diagnosis and treatment to get effective therapy and with whatever variant you're dealing with is very important. And usually then, once you control the disease, they will do very well long term.
Yes. Okay. Fantastic. Thank you. Thanks, Estelle.
So thank you very much from our
Alrighty.
side. And thanks, Prof. van Ria. Really appreciate this session, and we appreciate the support that we've had for the session. And thanks, Zainab. Thank you very much. It was very, very interesting.
Thank you.
Great. Thanks, everyone. Have a lovely afternoon and a lovely week, and enjoy London.
Yeah, thank you. I do. Okay, bye. Bye, everybody. Thank you.
Okay, everyone. See you next week. Bye-bye.
Thanks, Zainab. Bye.